Hi. Good evening, everyone. So we come back and we are discussing a new drug, Acitretin, in dermatology. This week, we are continuing our lectures. We were discussing retinoids for the past few weeks. We have covered introduction to retinoids, topical retinoids, isotretinoin, and this week we'll continue our discussion with Acitretin. Now, Acitretin is a second generation monoaromatic retinoid, and its major use lies in treating psoriasis. Nearly all variants of psoriasis, like pustular, erythrodermic, okay, chronic plaque psoriasis, and these are the major indications of acitretin. Now, the way acitretin acts, or how it is slightly different from isotretinoin that we discussed last week, is that acitretin has more action on the keratogenesis process, the process of keratinization, the process of formation of new skin layers, and that is a bit different from its predecessor, the isotretinoin. In last week, we discussed that isotretinoin has major action on sebocytes or sebum secretion. Addition of acitretin leads to normalization of keratin formation and the process of the formation of layers of the skin, namely action on the granulosome layers and the other layers of the skin. So that epidermokinetics, which is disturbed in psoriasis, leading to altered keratinization, is corrected by acitretin, and that is why acitretin becomes a good drug to be used in psoriasis and other keratinization disorders. That's why the use is not much in acne, while isotretinoin is used very much in acne. But acitretin has good beneficial profile when we are using it in psoriasis, and that's how the drug which is or a good systemic retinoid to be used in psoriasis is acitretin. So without further much ado, this would be a different video. This would be a shorter video, and we'll quickly discuss the role of acitretin in dermatology. So as I said, that acitretin is a second generation monoaromatic retinoid. Let me just draw it again. Yeah. Second generation monoaromatic retinoid. So what do we mean by that? Monoaromatic means that there is one aromatic group in the structure. Okay. The use is mainly in severe psoriasis and combination therapy. That means addition of other therapies like calcipotriol or PUVA therapy, or addition of, let's say, cyclosporin or methotrexate. It's a good agent to be used in combination, and the efficacy is more in combination as compared to monotherapy. Etretinate is a prodrug. Etretinate is the ethyl ester form of acitretin, and when we give etretinate, it gets converted into acitretin, and acitretin becomes the metabolite which is responsible for all the retinoid specific actions. So active metabolite is acitretin, while etretinate acts as a prodrug. Okay, but there is a very crucial difference between etretinate and acitretin. Acitretin is less lipophilic than etretinate. Okay, so there's no sequestration into deep fatty storage sites. Now, what do you mean with that? If you give etretinate to a patient, etretinate is highly lipophilic. Okay, so etretinate is highly lipophilic. That means it loves fat cells. So etretinate gets sequestered, gets attached or engulfed in the lipocytes, and then it is released very slowly. So much so that the half-life of etretinate is actually in years. Okay, it's about 120 days. Okay, the half-life, I'll just write it here. T-half of etretinate is about 120 days. But acitretin is less lipophilic than etretinate. That decreases the T half of acitretin to about 50 to 60 hours. And this distinction is very important because the retinoids are slowly released from the fat cells. The amount of time for which the retinoids can cause the side effects also increases. That is why the side effects associated with etretinate can be seen for a longer duration as compared to that with acitretin. Okay, we'll discuss this relationship between acitretin and etretinate in subsequent slides. So acitretin binds to all RAR types and all RXR types receptors, but the binding is poorly. It does lead to the action, but the binding to RAR and RXR receptors is poor. The major action is through cytosolic retinoid acid binding protein 2. Okay, and the major action on CRABP2 leads to good improvement in psoriasis. How? We'll discuss that in the subsequent slides. Why acitretin is actually a good drug for psoriasis because of this particular property. As we have mentioned, that acitretin is highly lipophilic, but less lipophilic when compared to etretinate. Okay, absorption is increased with fatty meals. Roughly 5 to 8 times increase can be seen with fatty meals. Okay. Half-life is about 50 to 60 hours. We have discussed that. Bioavailability is 60%. It's a very strong molecule, strongly binding molecule to albumin. Less than 5, sorry, less than 5% binding is seen to lipocytes. Okay, so that's what we meant when we said that it is less lipophilic as compared to etretinate. Less than 5% of acitretin binds to lipocytes and stays there. It has high affinity for CRABP. We have already discussed that in the last slide. Okay, excretion is mainly due metabolites. We have already told you that acitretin is an active metabolite, and that is how the actions take place because of the conversion of etretinate into acitretin. If you give etretinate, or if you directly give acitretin, that's the drug which is going to act as a systemic retinoid. The excretion is through urine and feces. Mainly, it is converted into metabolites like glucouronides and excreted in bile, and through feces, acitretin gets excreted. Now, if you want to know about the mechanism of action of systemic retinoids, I would suggest that you go 2-3 weeks back and see the video on introduction to retinoids. We have discussed the mechanism of action of retinoids in a very detailed manner in that video. If you go through it and then come back to this video and learn about the mechanism of action of acitretin, you will be able to understand it better. So acitretin inhibits epidermal proliferation. Okay, so the formation of newer epidermal cell layers is inhibited by acitretin. There is also regression of inflammatory changes. It also reduces capillaries. So there's inflammatory changes that happens in the level of skin, in the level of epidermis and dermis. That is also inhibited by acitretin. The capillary formation is also inhibited by acitretin. And we know that in psoriasis, there is capillary hyperproliferation. Okay, that's why you see dilated capillaries in biopsies, isn't it? So if a drug is reducing capillaries, is reducing inflammation, is reducing epidermal proliferation, it's a good drug for psoriasis. Okay, it's a good drug for psoriasis. There's also increase in granular layer and the reappearance of stratum corneum layer. So basically what acitretin is doing is that the formation of layers becomes proper when the patient is taking acitretin. Acitretin also inhibits epidermal ornithine decarboxylase. It's a very important enzyme for DNA synthesis, for basically synthesis of cell organelles. And when that is inhibited, the rapidly dividing cells are not able to divide that fast. So all the immune mediator cells like lymphocytes or neutrophils, they're not able to divide that fast. It also stimulates macrophage, lymphocytes, and Langerhans cell activity. Now, this statement might look counterintuitive that at one point acitretin is decreasing inflammation, while in other point it is stimulating the activity. Just make sure that this is the activity of normal cells. Okay, and all the abnormal cells are not able to divide, they are not able to properly proliferate, and that leads to destruction of abnormal cells, and this is the main mechanism of action in carcinomas. So like isotretinoin, acitretin is also used in a treatment of the various kind of lymphoblastic in leukemias. And it's a part of the protocol, and that is the main reason how in carcinomas it helps. So here we have mentioned 5 mechanism of action of acitretin. So you can just go through it. Just repeat with me. It inhibits epidermal proliferation. It decreases inflammation and reduces capillaries. It increases the normal layers of skin like granular and corneum layer. It inhibits epidermal ornithine decarboxylase, and it stimulates the proper functioning of macrophage, lymphocytes, Langerhans cells activity. Okay. Now, as we have mentioned earlier, that the binding is stronger to CRABP. Okay. CRABP less than RAR. Okay. CRABP was found to be about 8 times increased than normal in psoriatic lesions. So if you have a skin, you have a certain number of CRABP2, you have skin and an psoriatic plaque. CRABP2 is increased roughly about 8 times. So the amount of CRABP2 present at the level of psoriatic lesions is high. And since acitretin has a preferential binding to CRABP2, it gets sequestered mainly in the psoriatic lesions where the action is required. That makes acitretin a good drug for psoriasis. Other disorders like diarrhea, PRP, and lamellar ichthyosis also have increased amount of CRABP2, and that is why acitretin has shown good improvement in these disorders. Other is epidermal growth factor induced inhibition of cell proliferation. So this is the sixth mechanism. Okay, epidermal growth factor induced inhibition of cell proliferation. Normal EGF inhibits the cellular proliferation in the formation of new keratinocytes. So if EGF is not working properly, the keratinocytes can divide unhindered, unstopped, and because of that, you can have altered keratinization. What acitretin does is normalizes EGF to EGF levels, and because of that, the rapid growth that was happening in the diseased epidermis gets quieted down so that the turnover rate is decreased. We know that in psoriasis, the epidermal turnover rate is increased significantly. If you let's take that as a homework for you, that you mention the normal epidermal turnover rate and also mention the epidermal turnover rate in psoriasis in the comment section. Let me see if how many of you know about it. Okay, seventh mechanism is cyclic AMP dependent protein kinase. Okay, now cyclic AMP activates different kind of kinases. There are two names that I mentioned is R1 kinase and R2 kinase. R1 is responsible for cell proliferation and R2 is responsible for differentiation and growth inhibition. Okay, R2 is decreased in normal psoriatic fibroblast, and if R2 is decreased, there is no proper differentiation, there is no growth inhibition, and because of that, the proliferation keeps on happening. Okay, this decrease of R2 is stabilized or is improved by acitretin. R2 increases and differentiation happens, growth inhibition happens, and the cycle of increased skin formation is limited. Okay, so there are now 7 mechanisms of action which are in use in majorly the psoriatic disorders and the keratinization disorders, and that is the in summary of the mechanism of action of acitretin, which is a bit different from last week's video on isotretinoin. The eighth, or rather, this is a repeat, so not eighth, the inhibition of ornithine decarboxylase, which is a rate determining step for polyamine synthesis, is required for good cellular growth and proliferation. Now, what do we mean by that? Ornithine decarboxylase is a good enzyme. It's an important enzyme, a rate determining step for proper polyamine synthesis. Proper polyamine synthesis is required for good cellular growth and proliferation. When acitretin inhibits this enzyme, the cellular growth doesn't happen, the proliferation doesn't happen, and eventually the epidermal turnover rate, okay, the epidermal turnover rate is also decreased. Eighth is minor mechanism of action, that is altered junction interaction between keratinocytes. Now remember, interaction among two cells which are attached together is a very important mechanism of stopping the cell growth. It's one of those mechanisms through which a cell knows that the cell is not supposed to divide unhindered. If that kind of junction interaction gets wrong, then the cell keeps on dividing. Acitretin stabilizes that so that the interaction between two cells happens properly and the cell knows that I don't have to divide so much. And that is how it helps in keratinization disorder. It also decreases intracellular calcium. So in subsequent future anytime when I'll be discussing the process of keratinization, you will know that intracellular calcium is a very important trigger for keratinization. Okay, it's a very important trigger for keratinization, and if that is decreased, keratinization doesn't happen. So again, because of this, the epidermal turnover rate is decreased. So that is how acitretin helps in disorders in which the proliferation is going very fast, uncontrolled in an uncontrolled manner. The anti-inflammatory action of acitretin is mainly because of concentration-dependent inhibition of mitogen-stimulated T lymphocytes. That means normal lymphocytes are not inhibited that much, but if you give some kind of mitogen, some kind of agent to rapidly divide those T lymphocytes, this division is inhibited by acitretin. So in all disorders in which the lymphocytes are rapidly dividing, you give acitretin, it helps. For example, in disorders like lichen planus. Okay, in severe lichen planus, acitretin has shown to have marked improvement. That is the reason. Inhibition of antigen-presenting properties of epidermal cells is another mechanism. Limits the migration of neutrophil, which again helps in psoriasis. We know that psoriasis is a neutrophil-mediated disorder majorly, and it is characteristically seen that neutrophils are migrated to the site of skin. So when acitretin limits the migration of neutrophils, it helps in psoriasis. Acitretin also increases interleukin-1, which is a good modulator of inflammation. So interleukin-1 is supposed to control inflammation, either increase it, decrease it. If that is increased, it provides a negative feedback loop and decreases the action of interleukin-1, modulating inflammation. So in disorders in which interleukin-1 can be increased, for example, like psoriasis, in which IL-1 is increased, so there's increased inflammation. Acitretin increases interleukin-1 to modulate that inflammation. In other words, if you increase the concentration of a molecule, the negative feedback mechanisms will decrease the function of that molecule. That is how the acitretin modulates the inflammatory activity. Now let's come to etretinate. As we have already said that etretinate is a prodrug. So it's a prodrug. It gets converted to acitretin. Etretinate is ethyl ester of acitretin. Okay, so retinate because it's a retinoid and Et comes from ethyl. So ethyl ester of acitretin. It is 50 times more lipophilic than acitretin. It's very highly lipophilic drug. It gets attached and ingrained in the fat cells. Alcohol intake is important. Why? See, you have etretinate. It's a prodrug, gets converted into acitretin. Acitretin is active. A for acitretin, A for active. Etretinate is prodrug. Okay. Alcohol can cause re-esterification, that is conversion from acitretin to etretinate. So let's say, and we have told you that etretinate has a half-life of 120 days, while acitretin has 50 to 60 hours. So for example, if a patient is on acitretin, okay, and they drink alcohol, and it is said that even the slightest amount, even the smallest amount which is present in different kind of cough syrups can also lead to re-esterification. Okay, so no alcohol while the patient is on acitretin. Okay, what is going to happen is that if a patient is taking acitretin and you give alcohol, re-esterification can happen and acitretin will be converted to etretinate back. Okay, and this etretinate is 50 times more lipophilic. Okay, so what will happen is you give acitretin under the action of alcohol, it gets converted into etretinate, and this will get ingrained in the fat cells. Ingrained in fat cells. And if it gets ingrained in fat cells, it's going to stay for a long, long time. Okay, and if it stays for a long time, the efficacy, the side effects is also increased, the duration is increased. So much so that contraception after stopping acitretin is for 2 to 3 months, while for etretinate, it is 2 to 3 years. So if your patient has taken alcohol in any time during acitretin therapy, there is a risk of conversion to etretinate. And if etretinate is formed, it will go inside the fat cells, and the half-life will increase tremendously. In that case, you cannot stop contraception at the end of 3 months. You have to continue contraception for 3 years to limit the risk of exposure of fetus to the etretinate, which might have formed because of alcohol intake. So, no alcohol while the patient is on acitretin, and tell them why no alcohol, so that they avoid other sources of alcohol, like there are cakes and there are bakeries and desserts which have alcohol, so they can limit their exposure to that. So here we can see the structure of acitretin and etretinate, and you can see the ethyl group here, the ethyl ester group here instead of a carboxylic acid group. And that is the main difference between the structure of etretinate and acitretin. So we have discussed what is acitretin, we have discussed pharmacology, pharmacokinetics, we have discussed the mechanism of action. Now we'll discuss the use. The major use is in psoriasis. The most important use is in psoriasis. The dose is about 50 milligram a day, but it changes depending on the response of the patient. It roughly takes 4 to 8 weeks for significant improvement to happen. So acitretin is actually a bit slow drug, and that makes it a good maintenance agent. Okay, so you start with some drug which is fast acting. For example, you start with cyclosporin. Okay, you start with the, let me just write it again. You start with cyclosporin, so that you can have rapid resolution of symptoms and then maintain on acitretin. Okay, articles mention that the action on pustular and erythrodermic psoriasis is better as compared to chronic plaque psoriasis. It does work on psoriasis, but the action on erythrodermic variant and pustular variant is good. There is about 34 to 50 patients show a PASI 75. Now, what is PASI 75? That is 75% reduction from baseline. In 34 to 50% of patients, we see PASI 75 improvement in about 12 weeks. Okay, it's a slow acting molecule, good maintenance agent, so you can use it for rotational therapy. Rotational means you keep on switching one modality with another modality, so that one single modality doesn't have a lot of side effects and the dose is limited. For example, you maintain the patient on methotrexate for a few months, then maintain on acitretin. So that is how you keep on rotating the modalities. Okay. In this graph, you can see that as compared to placebo, 10 milligram acitretin, 25 milligram acitretin, and 50 milligram acitretin, 25 and 50 have nearly similar efficacy, and they are not that far behind between 10, but all of their doses are significantly better in reducing the PASI score as compared to placebo. So in the first slide, so in the first slide, we discussed that the combination treatment with acitretin is better as compared to monotherapy. One of the good combination of acitretin is with PUVA. The combination is known as REPUVA. REPUVA. So in Re means retinoids and PUVA is PUVA. Okay, so this is the combination. So if you want to use acitretin or any other retinoids with PUVA, you should start retinoids first, give them for 2 weeks, and then give PUVA. Why? Because in disorders like psoriasis, just starting with psoralen can induce photocoagulation. That means increase in disease activity in the starting times of PUVA. Let me just write it properly. Photocoagulation So what happens is that if a person has active psoriasis and you expose them to sun because of PUVA therapy, that can cause slightly increased irritation, inflammation if the dose is not correct, and that inflammation will get translated into new lesion formation. Okay, so that to prevent that, if you are using retinoids with PUVA, you start retinoids first, give for 2 weeks, and then introduce PUVA with very slow increase in the fluence levels. So the combination decreases the irradiation doses. It decreases total time for which you are giving for phototherapy. Remember, there is a theoretical risk of developing skin cancers with PUVA and phototherapy. So if you decrease the time, decrease the dose, it eventually helps. The combination has better efficacy, less side effects of each other drug. Lower doses of acitretin is used, leading to less side effects, and lower doses are used, lower time is used. So side effects of PUVA is also limited. The combination does have less efficacy along with UVB. That means retinoid plus UVB is less efficacious than retinoid plus PUVA. So if you want to give retinoids and a phototherapy, it's a good idea to start with PUVA. Okay, so repeat after me. The combination with PUVA decreases doses, decreases time, decreases the total doses of acitretin, and but it is found to be efficacious in psoriasis. So here we can see that acitretin with PUVA, which is darker green, compared to etretinate with PUVA, which is light green, compared to placebo with PUVA, which is extremely light green. I don't know what to say, very, very light, faded green. So we can see that the combination of acitretin and PUVA works better as compared to etretinate and PUVA, and both of them work together for as compared to placebo. So the number of exposures are decreased as compared to placebo, and also the duration of treatment is decreased as compared to placebo. Other use is in pustular psoriasis. In an article which we have mentioned here, it is mentioned that about 385 patients were treated with different modalities, different antipsoriatic drugs, and etretinate showed improvement in about 84% of patients compared to methotrexate, cyclosporin, and oral PUVA. Okay, 76 for methotrexate, 71 for cyclosporin, and 46% for PUVA. So, Etretinate, it has been said that in terms of efficacy, the data for Etretinate in some instances can be extrapolated to acitretin. Why? Because Etretinate gets converted into acitretin in the body. We have mentioned that it's a prodrug. Acitretin is a good drug for severe generalized pustular disease. In severe generalized pustular disease, you give more aggressive treatment with slightly higher doses, ranging from 50 to 75 milligram per day. So remember that along with anti-inflammatory action, there is also inhibition of neutrophil migration, and that helps in severe generalized pustular disease. Response can be seen in as quick as 10 days, and you have to taper acitretin and maintain on very low dose after the pustules are cleared. So you give acitretin in severe case till the pustules clear, and then slowly taper. If the patient is responding, then taper and stop. If not, then use very small doses as maintenance therapy. Chemoprevention. Now, like all retinoids, there have been multiple studies that low levels of low doses of acitretin can prevent formation of new carcinomas. So acitretin has been shown to decrease actinic keratosis, prevent development of new dysplastic lesions when compared to placebo. So there are certain indications where acitretin can be used to prevent carcinomas. For example, yeah, for example, numerous non-melanoma skin cancers, about 5 to 10 per year, developing about 5 to 10 NMSCs in a year. Second is innumerable actinic keratosis. That means multiple, widely spaced apart actinic keratosis. So it's a good idea to give acitretin. Accelerating frequency of NMC. That means the frequency, the rate of development of NMCs is increasing. Multiple NMCs in high risk locations like head and neck. So if there's in the head and neck which will continue to get sun exposure, you may use acitretin as a chemopreventing agent. eruptive keratoacanthomas if they are very fast growing, high risk NMSC, which have more than 20% risk of metastasis, or if the NMSC is already in metastasis phase. So these are the indications in which acitretin should be used as a chemopreventive agent. The regimen is that you increase the dose. That is, you start with 10 milligram every other day for week 1 and 2, the first 2 weeks, then every day for the next 2 weeks, then 20 milligram a day for a month, in which you keep on adjusting doses depending on response and side effects. So that's how you start. You start with lower doses and then you escalate if you're preventing for carcinoma development. These are some other uses, so we'll quickly go through them. Remember, all you have to do is just remember the headings. So, infections, vesicular disorders, connective tissue disorders, appendigeal disorders, mucosal disorders. Okay, so these include recalcitrant warts of scalp, Buschke-Lowenstein, blastomycosis, elephantiasis nostrus verrucosa. Okay, vesicobulus include IgA pemphigus, pemphigus vegetans, CTDs like lupus erythematosus, post-irradiation morphia, Ellis, graft versus host disease, appendigeal disorders like HS, Pachyonychia congenita, erosive pustular dermatosis, disorder of mucosa like oral leukoplakia, bovine papulosis. Okay, miscellaneous include miscellaneous. By miscellaneous, we mean that there are multiple isolated case reports to tell that acitretin is a good efficacious agent in these diseases. These diseases include granuloma annular, hyperkeratotic hand eczema, acrokeratosis vericiformis, Langerhans cell histiocytosis, lichen planus, amyloidosis, lipoid proteinosis, PUVA keratosis, arsenical keratosis, actinic keratosis, porokeratosis, bubbles. So I have mentioned so many diseases in which acitretin can be used. So you can easily mention a lot of them if asked in Viva. Now quickly we go through the adverse effects. I told you it will be a short video. The adverse effects are dose dependent. So dose dependent side effects are there. Side effects like dry skin, eyes, nose, lips, cheilitis are the most common and they occur within weeks. Alopecia can happen in high doses and if acitretin is given in long duration. Dose-related transaminitis occur in about 15% of the patients. Hypertriglyceridemia can be seen in all patients in various varied concentrations. Okay, all the side effects are reversible. That means once you stop the drug, the side effects tend to come back to normal levels. Now, teratogenicity. Like all retinoids, acitretin is category X, so you cannot give it in pregnant females. Okay. If you give in females of reproductive age group, the contraception period should be about 2 months post stopping acitretin, and 2 years if etretinate is the agent. Okay. The reason I've already told you that etretinate is lipophilic, so it tends to reside in the fat cells and then slowly released over a period of 2 to 3 years. So if you have given patient etretinate, the contraceptive period is about 2 years to 3 years. If you have given acitretin, so contraception period is about 2 months to 3 months. Okay, so that is why acitretin is a good drug to use because the duration of contraception which is to be given is shortened. Okay. Now, the way acitretin acts as a teratogenic agent is that it suppresses chondrocytes. It suppresses cartilage formation by blocking the differentiation of chondrocytes. So, the chondrocytes are not able to develop properly from chondroblast. If the cartilages are not developing, there will be limb and mid-facial deformities because of acitretin, which is seen in the acitretin-induced embryopathy. Okay. Remember, alcohol, even a little bit, converts acitretin to etretinate. So, if a patient is on acitretin, you give a little amount of alcohol, gets converted into etretinate. Etretinate goes into fat cells, and the duration of risk to fetus increases from 2 months to now 2 to 3 years. That means 2 to 3 years after stopping the drug, the patient might still have a risk of embryotoxicity. Acitretin up to 50 milligram a day for 3 to 4 months did not induce any andrological or endocrinological changes in males. So hormonal changes are not that much seen for acitretin. And also, if acitretin is taken by males, there are evidences of acitretin presence in spermatozoa and ejaculate, but whether that leads to embryotoxicity, there is no particular evidence for that. A good idea should be that in males of reproductive age group, if the indication of psoriasis warrants it, use acitretin. About 5% of patients can have bone side effects or bone related side effects. These side effects include diffuse idiopathic skeletal hyperostosis, degenerative spondylosis, arthritis, syndesmophyte formation in the cervical, thoracic, lumbar region. Effects of acitretin on bone can be potentially serious and justify careful monitoring. That means keep on monitoring. If there are bony pains, if there are pains or complaint of pains by the patient, make sure you get some X-rays done to find out if that kind of syndesmophyte formation or any kind of premature epiphyseal closure is happening. Okay. Remember, if you're using them in adults, people who are more prone for gymming and going into sports and everything, they play active sports, they can have increased chances of this kind of bone and muscle involvement. Now, drug interactions. Drug interactions are multiple, like any other drug. I've just highlighted few important ones. For example, with tetracycline, like all retinoids, acitretin has a theoretical risk of benign intracranial hypertension. That means increasing the pressure inside around the brain. In methotrexate, which may be given as a part of combination or sequential therapy, that you give methotrexate and acitretin together, but the chances of liver toxicity increases substantially. So be careful in that. Progesterone only OCPs or mini pills. If the patient is taking this kind of mini pills, acitretin reduces the effectiveness of mini pills. Now remember that acitretin is a category X drug. Okay, so if a patient of reproductive age group, especially female, if they are on category X drugs, they need to be careful about the level and the extent of contraception. They need to use two different methods of contraception. And if they're relying only on progesterone OCPs, that could be wrong because acitretin decreases the effectiveness of mini pills. Okay, phenytoin, acitretin can enhance the side effect of phenytoins. So side effects like slurred speech, which I'm having right now because I'm very sleepy, slurred sleep, sorry, slurred speech, confusion, coordination and balance problems. These are all side effects of phenytoin, which are increased if they are taken concomitantly with acitretin. Okay. Vitamin A supplements and other oral retinoids. Vitamin A supplements and other oral retinoids can cause increased chance of nausea, vomiting, loss of balance, or blurry vision when they are taken with acitretin. Okay, without further ado, I told you it was a very short video. I think it is roughly 35 minutes that we have gone through the video. These are some reading recommendations. Uh, for example, this review is very good if you want to know about acitretin. This is good in which you want to know about psoriasis. And if you want to know about usage in pediatric psoriasis, there have been good reviews which tells you more about the mechanism of action, the associated side effects. So if you want to read, you can go through it. Otherwise, this video is all that you require on acitretin. The major use lies in psoriasis. Okay, other conditions I've already mentioned, and that is where I use it very less because my personal favorite for psoriasis is methotrexate or other immunosuppressive agents. But remember that acitretin, being a retinoid, is not an immunosuppressive agent. Okay, it's more of a subduing keratogenesis agent. Okay, it decreases the epidermal turnover. So you can use acitretin in immunocompromised states. For example, HIV associated psoriasis or any other condition. If there's HIV plus psoriasis, acitretin becomes a very good drug because it won't have additional immunosuppression. So if you want to know more about acitretin, just read these three articles. They are very good articles. So without much further ado, we have finished this video, and it was a short video, I agree. But this is all that you need to know about acitretin. I have personally used it in one patient. He was 12 years old child with generalized verruca plana, and I've used in one patient who was retropositive but psoriasis. So in those patients, it was significantly helpful. It was very helpful with good improvement, and that is where you can use acitretin, mainly in immunocompromised patients. So because we know that retinoids are not immunocompromised, suppressive, they are immunomodulators. Okay. So without much further ado, I will finish this video. If there's any doubts, suggestions, queries, I would suggest that you write them in the comment section so that other people can read that comment and learn from it. If you want to email me, it's always welcome. You can email me at my email ID, which is mentioned here, or you can directly contact me. I may take time, but I try to answer each and every one of your queries. So without much further ado, adios and bye-bye. Enjoy your weekend. Bye.